السلام عليكم طلابنا الأعزاء. محاضرتنا لهذا اليوم هي عن Furcation Involvement and its Management. Furcation Involvement means the invasion of the bifurcation or trifurcation area of the multi-rooted teeth by periodontal disease. We know that the primary etiological factor in the initiation and the progression of periodontal disease is bacterial or the plaque biofilm. The long-standing effect of the dental plaque will lead to increased inflammation and periodontal tissue, which will lead later on to the involvement of the furcation area. There are some terms that is frequently used in furcation involvement. From these terms, the root complex. The root complex is that portion of the tooth that is located apical to the cemento-enamel junction, and it is usually covered by root cementum. It consists of two parts. The first part is called the root trunk and the other part is called the root cone. The root trunk is the distance from the cemento-enamel junction to the line of separation of the furcation area. And the root cone is the divided portion of the root complex, while the root trunk is the undivided portion of the root complex. Other term is the furcation entrance. The furcation entrance, it is the transitional area between the undivided and divided portion of the root. The fornix of the furcation, it means the roof of the furcation. There are some anatomical variations between individuals that have to be taken into consideration when diagnose and treat the furcation involvement teeth. From these anatomical considerations are the root trunk, root surface anatomy, enamel projections, and accessory canals. The root trunk, as we said, it is the distance from the cemento-enamel junction to the line of separation of the furcation area. We have short trunk and we have long trunk. The short trunk, it is easily to get involved by the furcation lesion, by the periodontal disease. While the long trunk, it is difficult to be involved by periodontal disease, but when it is get involved, it will be difficult to be treated. The root surface anatomy, we have the fusion between divergent roots. We have the roots, either it's widely separated roots or close to each other or fused roots. The very good prognosis considering with the widely separated roots, because here it's widely divergent roots and the bony support, the interradicular bony support between the two roots, it is much better or higher than the fused root. يعني هنا البوني سبورت بالنسبة للوايدلي separated روت تكون أكثر من البوني سبورت بالنسبة للفيوز روت، فلذلك يفضل حتى من ناحية التريتمنت هي أن تكون widely separated roots. يفضل العلاج مالتها تكون أحسن و it is better prognosis. Also there are root concavities in the mandibular and maxillary molars with the percentages that is shown in this slide. We have the cervical enamel projections in which the enamel will be extended from the cemento-enamel junction until it reaches to the furcation area, and this is about 13% of the molars having cervical enamel projections. And these projections will favor the accumulation of plaque leading to periodontal disease in the furcation area. As we see here, the cervical enamel projection. Also, we have the enamel pearls. The enamel pearls usually it is found in the maxillary second molar near the cemento-enamel junction and extending into the furcation area, and its incidence is about 1.1% to 9.7%. Also, we have the accessory canals in the pulp. The presence of these canals will lead to extension of the inflammation from the pulp if it is infected into the surrounding periodontium, and this will lead to endoperio lesion and may lead to destruction of the interradicular bone and periodontium, and lead to the inflammation will be spread to the periodontium, leading to involvement of the furcation area. Let us study the position of the tooth in the arch. We will take the anatomy of the mandibular molars. Usually mandibular molars having two roots, the mesial and the distal roots, widely divergent roots, mesial and distal. So the furcation of the mandibular molars, it will have a facial furcation and lingual furcation. While the maxillary first premolar having buccal and palatal roots, the furcation of the maxillary first premolar is a mesial. It has a mesial furcation and a distal furcation. We have to consider, or we have to take into consideration that the maxillary first premolar, its furcation is located many millimeter apical to the cemento-enamel junction. That means it has a long trunk. And what about the maxillary molar teeth? The maxillary molar usually having the buccal root is divided into mesiobuccal and distobuccal roots, and it has the palatal root. So the furcation of the maxillary molars, it has a mesial furcation and a distal furcation and a facial furcation. It has been found that the mesial furcation of the maxillary molars is located more toward the palatal surface, while the distal furcation, it is located near to the center of the tooth. The classification of furcation involvement includes three classes. Class 1, the horizontal destruction of the periodontal tissue do not exceed the 1/3 width of the tooth, while Class 2, the horizontal destruction of the periodontal tissue exceeding the 1/3 width of the tooth, but do not come to the whole width of the tooth, do not include the whole width of the tooth, while Class 3, the horizontal destruction of the periodontal tissue including through and through, which means the whole width of the tooth will be included by furcation involvement or by destruction. Diagnosis of the furcation involvement is including the clinical probing and radiographical analysis. The clinical probing, we have a specially designed probe that having gradings in millimeter indications so that to measure the amount of destruction of the furcation area. It is called the neighbor probe. This probe is specially designed a probe for the detection and measurement of the furcation involvement. From the radiographical analysis, we can locate and measure the interdental bony level within the root complex. But sometimes the radiograph is of limited value. For example, in maxillary molars, we have the superimposition of the palatal roots. It is there may be no radiolucency and no bony resorption appear in the radiograph. But when we examine the tooth clinically, we may find a severe amount of attachment loss that is not consistent with the picture of the radiograph. So sometimes the radiographical analysis is of limited value. Before deciding to do furcation treatment, we have to make a differential diagnosis, because sometimes when we found a radiolucent area or there is destruction in the furcation area, it may be not related to periodontal disease, but it may be there is a pulpal pathosis, and the infection in the pulp cause a lesion in the periodontal tissue of the furcation area. So the pulp have to be treated first. Endodontic treatment must be done first and then the periodontal treatment. Other differential diagnosis is the trauma from occlusion. The trauma from occlusion may cause tissue destruction in the furcation area or within the interradicular bone or area of a multi-rooted teeth. So we have to treat the trauma from occlusion before deciding to treat the furcation area.